Good morning, everyone. Thank you so much for the opportunity to be here. My name is Heidi Schumacher, and I oversee the health and nutrition portfolio for DC's state education system. And I'm thrilled to be talking about some exciting work that we've been doing in DC and with our friends in Baltimore to link pediatricians as part of the solution to chronic absenteeism. And so let's start with a mental image of what chronic absenteeism means and how it presents. So as was presented earlier, chronic absenteeism is defined as missing 10% or more of the school year. So in an average school district with 180 days, that means a child who's chronically absent is missing 18 days of school. And many folks might think, oh gosh, 3.5 weeks of school. And that may be the case in small circumstances. But what actually we see for many kids is this. It's actually missing 2 or 3 days a month, scattered throughout the year, in a way that many families have come to just normalize, as that's how things go. That this is, Johnny misses a couple days a month from asthma and a few other things, and folks, it may not even register as something that even requires attention. And yet when we think about a chart like this, an attendance record like this, why is this something not only that educators care about, but why is this something that a child health provider might care about? And the reason is, frankly, as all the great presentations this morning highlighted, because we know that chronic absenteeism is something that impacts the likelihood of academic success in that year, but academic success in one year predicts academic success in future years, which goes on to predict ultimate likelihood of graduation. And then we know, again, that educational outcomes and health outcomes are so interrelated. Additionally, we know in the health community that many of the same reasons that kids are coming to see us in clinic, the health barriers to learning that Dr. Bosch presented on, are the same things that are preventing kids from showing up in school, but also social determinants, transportation, homelessness, childcare. The same reasons that kids struggle to get to our doctor's appointments are the same reasons that kids struggle to get to school. And yet we often aren't totally aligned in our approaches to how we screen for those social determinants and how we recommend interventions. And so in DC, what we started to coalesce around with our friends in Baltimore was we recognize that child health providers have unique relationships with families and opportunities to move the needle on some of these mutually important concepts like health and social determinants, but how do we really leverage these child health providers? And what we came to was we really need to think about infrastructures, starting with how data is shared. Seeing a patient at the end of the year for a well child visit where a family so often says, yep, Johnny missed 15 days last year from asthma. It's too late to intervene then. And so we started to think about how can we use proactive, systematic data sharing, in our case, using the Health Information Exchange. The Health Information Exchange is a system through which providers already get access to health data coming from hospitals, labs, et cetera. And so now we have linked the DC Public Schools Student Information System to share attendance data with the Health Information Exchange. That Health Information Exchange then matches those students against their patient records and pushes reports to primary care doctors based on the patient panels in the Health Information Exchange so that they can proactively, on a biweekly basis, get a report of how many of their patients have missed school, what that portfolio has looked like. And we also said infrastructurally we can set up a data system, but we know that that's going to require consent, in this case from FERPA, or the Federal Education Rights Privacy Act, which is essentially the educational equivalent of HIPAA. And luckily, since we're in DC, we just took a quick jaunt down on the metro to the U.S. Department of Education and met with the lead FERPA attorney there to get guidance on what we needed to cover the sharing of these records. And we were pleased that his feedback was, you need to follow basic FERPA standards, but a simple consent form is really all you need. And so we set up the infrastructure and then said, well, who are we setting it up for? We need to really find the right folks in the school side and the clinical side to really engage in a pilot fashion on this. And so we looked at what schools, in our case in DC, and our friends in Baltimore doing much the same thing, what schools have engaged leaders who are willing to invest in the resources and staff time to pilot this? Where are there diverse demographics of students so that as we're testing this concept of consenting for data to be shared through this system, We knew that, for example, newly arrived immigrant families may have different concerns and need different engagement to make them feel comfortable with this concept. We also engaged with staff to make sure that we had their feedback on whether this was even a good idea in the start, and then how we could really partner not only on the data sharing, but hopefully having that be a step to greater collaboration overall. We met with these parent and staff focus groups within the schools, got feedback on the concept and on the consent form. They marked up versions of the consent and informational materials. And then we ended up including in our school enrollment packages a simple one-page letter and a consent form. And with minimal additional engagement, about 75% of the families at these schools consented for their child's data to be shared. We were floored. And so now we have those consents, we have the infrastructure set up, but now we need to really figure out, well, how do we engage the child health providers so that they know once they get this data, what the heck they're supposed to do with it? And so we started by saying, well, what do child health providers in our area already know about, sorry, I'll move the slide. This is where we ended up. What do these child health providers already know in these pilot clinics about absenteeism, why they should care and what to do with it? So we did a survey through the local chapter of the American Academy of Pediatrics, got great response. That's helped us shape then what are the training needs for these providers. How do we help them understand not only the concept of chronic absenteeism, but also what resources are existent in the schools so that we're not just creating parallel structures, back to the silo slide presented earlier, but how we can do so in an integrated way. And also, how do clinics really operationalize this? Folks in the clinical space know adding one more thing that we need to screen for and talk with families about in short visits can be challenging. And so how do we leverage not only the providers, but also other staff to think about how we can use the whole clinic as a place where we can raise this culture of attendance and try to think about moving the needle. And so at this point, we're looking forward to really a process evaluation over the coming years. Do families consent, and what are the demographic differences for the population that do and don't consent? Does the data flow? Once the data gets to the clinics, do they have workflows in place to actually do something with it? And to build structures to crosstalk and try to understand pain points in both sectors for where we may see an opportunity for greater collaboration, with the ultimate goal with our outcomes evaluation in years 3 through 5 as we move through this pilot to look at, do we really decrease chronic absenteeism rates in these schools, and do we ultimately have the structure in place to increase health and academic outcomes and develop much more streamlined, aligned structures for resources. Thank you.
And finally, Jennifer.